Hello all, and welcome to this brand new episode of Orthodontics in Congress. I'm really excited to be doing this with you guys. So the plan is for me to go over the IOC, the International Orthodontic Congress, which is with the WFO. And I'm going to be summarizing the lectures that took place on day one. So there was, with all IOCs, there's loads and loads of lectures that happen, and this was no exception. I'm going to be summarising 14 of the lectures, which isn't all of the ones that took place on the first day, but it's the majority. A few were left out. They didn't quite lend themselves to the podcast format. I do hope you guys will enjoy it. Please do let me know what your thoughts are on this, and hopefully there's more to come if it's received well. Each individual lecture will have its notes. It'll be put on the website separately in the Orthodontics in Summary section, so please do look out for that. And of course, bear in mind, these are my notes taken from the lecture. Feel free to share them, and I hope you benefit from them. And of course, guys, if you like it, please do subscribe and let others know.
Welcome to the Orthodontics in Conference podcast, where Farouk brings you the summary of key lectures from orthodontic conferences around the world, with your host, Farouk Ahmed.
Hi guys, we're starting off with the IOC lecture by Ravindra and Nanda, entitled The Relevancy of Biomechanics in Clinical Orthodontics in 2020. Now, I really like this lecture. Ravindra went through the features of biomechanics and spoke about the magnitude, the direction, the duration, and all those types of things that I feel tend to live just in textbooks. Then he gave clinical examples, so I'm hoping to pass it on to you guys today. So he described why it's important to bear this in mind in 2020, now that we're looking at using more contemporary eye concepts such as TADs and also aligners, they all still have the same platform. They will still require biomechanics to be employed and implemented. Now he gave the example of the conventional intrusion arch, or the Ricketts utility arch, how it had higher forces anteriorly, and this would allow some intrusion to take place in the anterior segment. But there's always equal and opposite reactions, so therefore there would be a counterforce taking place posteriorly to extrude the molars. And he described how this force is taking place away from the centre of rotation. Consequently, we are going to have moments that take place. In the anterior segment, the utility arch is going to result in proclination of the anterior segment. But of course, there's something going on at the back end as well, and he broke this down really quite nicely and showed that there would be a counter moment taking place in that posterior segment, which would be in a clockwise direction, or to you and I, that will be a distal rotation that then takes place in that posterior segment. And that'll be quite a large moment, because it's away from the point of implementation of the force, which is in the anterior section. So he then gave this with respect to TADs. So, for example, carrying out space closure, using retraction hooks in the anterior segment. Now, what he described was that the line of action is the key, and as the space closes, the line of action will be changing. If our mechanics don't reflect that, then we will have loss of anterior torque, and we will retrocline those up incisors. So we need to vary our mechanics during that point of space closure. He spoke about anterior open bites used with TADs. Now, he has an extrusion arch that Ravindra likes to use for the anterior segment. But he spoke about, with this anterior extrusion occurring, there's going to be some intrusion posteriorly, but also there's going to be a mesorotation taking place. So he spoke about how TADs can be used to prevent these negative consequences of the biomechanics. And he uses a TAD in between the 5 and 6 region in the maxillary area to prevent the molars from moving, therefore allowing absolute anchorage posteriorly, preventing those biomechanics consequences in the posterior segment. He went on to speak about aligners. Now, he spoke about how aligners have got a weakness inside their process, and that is due to the plastic deformation that takes place of the material itself, and therefore we can never get a full expression of what's taking place within the aligners. So he described our anterior open bite case with using aligners, horizontal attachments in the anterior segment to allow for predictable anterior extrusion. He also described how this plastic deformation, preventing the prescription expressing itself as it were, results in greater need for refinement. He spoke about how 50% of cases needed refining in anterior open bite cases. That was a study by Harris in 2020. He also gave a note of warning that the case setups may show teeth moving in all directions, but these will not be reflective of the actual tooth movement or the biomechanics possible with alignment. Next is a lecture by Noriaki Yoshida, and it's entitled Smart and Visible Biomechanics, Optimizing Treatment Mechanics Based Upon Prediction Strategy for Long-Term Tooth Movement. Now, this was an interesting lecture. It was based mainly around finite analysis modeling, where Noriaki had thought through the effects of space closure. What I really liked about it is that he followed up one stage to the next, as each experiment led on to the next question. So the premise of this was about space closure and the bowing effects that takes place in that process. And just to clarify, the bowing effect is extrusion of the upper anterior incisors and also retroclination of that anterior segment due to uncontrolled tipping. This increases the overbite and extends treatment time. So the first premise of the experiment was to think about, well, can this bowing effect be prevented through the use of power arms in retraction? Power arms are crimped onto the arch wire and distal to the upper lateral incisors. So he looked at 6mm power arms and showed actually it reduced this loss of anterior torque, but the bowing effect still happened. Then experimented using a 10mm power arm on a 17x25 stainless steel arch wire on an 018 slot, and show that there was better control of the torque and a reduction in the bowing effect, but this time there was a cant that took place to the occlusal plane. And the last one was to look at a 12mm power arm on a 1925 wire and an 022 slot, and show this was much better control of anterior torque and far less changes to the occlusal plane. But it wasn't possible to prevent this process taking place completely. Bowing still occurred. So to compensate for that, he recommended using a compensatory curve in the anterior segment. So this is a curve of SPI to try and counter these effects taking place. Also the use of high torque prescription in the labial segment. But he explored this further and found that actually if you put compensatory curve in the anterior segment, this actually resulted in a greater increase in friction. And he stated that how the friction already is quite high in space closure, specifically towards the end stages, where the coefficient of friction is a greater consequence at that point. So he spoke about all ways of reducing this friction from occurring. And he spoke about changing the arch wire, having a wire which is rectangular in the anterior segment for the torque and round in the posterior segment to reduce the binding. He also looked at, well, when you put forces onto this power arm, how is that then distributed to the actual labial segment? And he spoke about how there's a high force on the canine of 60 grams, but actually the lateral incisors and central are 10 to 20 grams of force. And his solution to this was to have separate retraction for the canine, for example, the elastomeric chain, but also to have elastomeric chain going to the lateral incisors. And this would allow space closure to take place with a relatively even force on both teeth. He finally spoke about the rowboat effect. So to clarify, this is when we're trying to maintain the anterior segment during space closure and prevent torque from being lost, but actually end up losing posterior torque as a consequence. And his solution to this was quite similar to Ravindra Nanda's lecture, where he spoke about the use of TADs. So TADs being used prevent the biomechanics from expressing themselves in that posterior segment. He also looked at space closure using loops and how this can prevent the loss of posterior torque. Having said that, he tried to look at this in a finite model analysis and show that there's still significant anterior torque loss, even if a 30-degree gable bend was incorporated into the appliance. The efficient treatment in the Class 2 malocclusion. He started off by describing the timings of functional appliances for Class 2 cases and how the difference that takes place with respect to growth. So in a meta-analysis, relatively recent in 2015 by Periodonics, showed that in pre-pubertal patients, there was about 1 millimeter of mandibular growth length, whereas pubertal patients showed almost 3 millimeters of increase in mandibular length. And what is this ideal time? Well, it's not a chronological time, but it's something to do with the rate of development. This has been shown to be cervical spine maturation level 3, which achieves this pubertal growth effects on the mandibular length. He went on to speak about individual responses to functional appliances. So even when they're in this CS3 stage, There still can be a massive variation in mandibular growth. This was by Bacchetti in 2001. So what are good responders and what are bad responders? This was Franchi's work from 2006, and he looked at the condylion to gonion to menton angle from a cephalogram. And he found that the poor responders had greater than 128 degrees. Good responders were between 123 and 128, but the excellent responders were less than 123 degrees. So how do I interpret that? Well, that's really the low angle cases. And it also shows that they have an element of mandibular retrognathia. Now, in his study, which was interesting, he also looked at the effects of gender, age, and other cephalometric variables. And the only significant predictor to growth of the mandible for class 2 functional cases was the condylion to gonion to menton variable. Now, he asked a follow-up question, which was, well, what are the long-term effects of functional appliance therapy? This was a paper by Pavoni in 2017. I think this is the holy grail when it comes to class 2 studies at this stage. What we want to know is, well, does it actually cause long-term changes? Here they looked at pubertal patients who had functional appliance therapy and also pubertal patients as well. Now, the pre-pubertal patients had an acceleration of mandibular growth during the functional appliances, but it was found to have no long-term effects. And this was looking at quite a large age range, from 9 years of age when they were treated up to the age of 17. Now, interesting, the pubertal patients, those guys at CS3, those guys who are in the good position to get growth, they showed an overall increase in growth of the mandible of 5.5 millimeters. And this was maintained greater when compared to the pubertal patients, long-term up to the age of 18, showing that actually there is some skeletal growth which a functional appliance can achieve. Now, from my perspective, this particular statement or finding has been shown to be different in the other literature which is out there. So I'm looking forward to seeing more research into this longer-term aspect of functional appliances to make a firm decision as to what actually happens. Next is a lecture by Peter Ngan entitled Early Treatment of Class 3 Malocclusions. Peter described the ideal case for Class 3 interceptive treatment, that being a low-angle functional shift case. He described the success rates from a systematic review by C. Chung Woon in 2017. And C. Chung Woon is a chap who I studied with, who's from Malaysia, so shout out to C. Chung, hope you're doing well. Coming back to the lecture, his systematic review showed that the overjet on average improved by 2.5 millimeters with an increase in A and B by around 4 degrees. However, these findings were only in the short term. Now, there are longer-term studies which were carried out by clinical trials. Now, there's a 5-year and a 10-year follow-up that showed on average 75 to 80% stability to the changes with either protraction face mask, chin cup, or Frankfurt appliance. Now, what is the cause of relapse? Well, that's also been investigated. When class 3 cases relapse, so there's 25% of cases, it tends to be a combination of a reduction in the maxillary growth compared to average, which is a 2 millimeter deficiency, but also excessive mandibular growth compared to the control population of around 4 millimeters. Now, Peter then went on to describe how we're going to use protraction face mask. And he referenced Mohammed Al-Muzian's systematic review looking at the Alt-Ramek protocol. So, to you and I, that is where we carry out repeated expansion followed by constriction of the maxilla. Now, this is repeated over a 7-week episode. And the idea is it loosens the circumaxillary sutures, the things that hold the maxilla to the cranial base, to allow greater anterior-posterior movement. And this has been shown to increase the SNA by 1.2 degrees. So what I really liked was that Peter then gave his protocol of how he carries out interceptive class 3 cases. He chooses patients from the appropriate age from 8 to 10. And he implemented the Alt-Ramek principle. I really like that, the application of evidence-based practice into his own work. After 7 weeks, he would then fit the protraction face mask at an angle of 30 degrees to the occlusal plane. He would also actually have a lower arch fixed appliance 2x4 and run some class 3 elastics during the daytime. Now, patients would wear the appliance for around about 9 to 12 months. He then went on to describe some of the literature which looks at the use of bone-anchored maxillary protraction, or BAM as it's known. And that's shown that actually if we were to use bone-anchored anchorage with the combination of protraction and face mask, there'll be less relapse that takes place afterwards. But it's relatively new stuff, and Peter did make mention of that. Now, the decision-making. So what happens if they're older than the age of 8 to 10? Well, he described his decision-making process for the 11 to 14-year-olds. Part of that was looking at cephalometric changes, but also how they responded to initial interceptive treatment. Now, he described at the age of 11 to 14, he would carry out a similar process. But this time when it came to the rapid maxillary expansion, he'd incorporate TADs into it. Now, I thought this was really clever. The barriers that are there to maxillary expansion are preventing skeletal changes happening. By using TADs, we compensate for that. And therefore, when it came to the protraction face mask therapy which followed, he was confident he was going to get more skeletal changes happening. He also spoke about retention, which is a key component to it, and how in his vacuum form retainers he still leaves some buttons on the upper molar teeth. At night time, patients wears class 3 elastics from hooking the lower vacuum form retainer to the upper posterior buttons. The next lecture was by James Mcnamara, entitled Expansion in the Early Mixed Dentition, Is It Worth the Effort? So he described how there is a common occurrence of posterior and anterior crossbites, and also two-size discrepancy, and this early treatment is designed to correct those two discrepancies. So he uses two appliances to achieve this. He uses rapid maxillary expansion with a bonded appliance, which has some acrylic capping over the posterior teeth, and the mandibular arch, he uses a Schwartz appliance, which is a dental alveolar expansion appliance with no skeletal changes really happening. What's his decision-making process for expansion? Well, it comes down to the average size of the transpalatal arch. So from the study that he carried out with Ho in 1983 and also the Atlas in 1974, they found that the average child's transpalatal width is 32 to 35 millimeters. Now, adult is from 35 to 39 millimeters. And just to be clear, this is from the narrowest point, so from the palatal aspect of the teeth. And he concluded if the transpalatal arch width was less than 31 millimeters, that patient will require expansion. His second decision-making process was the mesodistal width of the central incisor. And this was interesting. In his study from the Atlas from 1974, showed that the males have 8.9 millimeter mesodistal width of the central incisor, and females about 8.7 millimeters. So he would work out that if a patient was 2 times the standard deviation, i.e. the mesodistal width of their central was 10 millimeters, he would actually delay this interceptive treatment because the patients are likely to require extraction therapy, so let's just do it all in one go. Next, looking at the arch length discrepancy. If there was a 6 millimeter arch length discrepancy, which was likely, again he would delay treatment because extractions are likely to take place. If there were 3 to 6 millimeter discrepancy, actually that's a good one to consider for expansion, as it may reduce the likelihood of needing extractions. Now his protocol was for maxillary expansion to activate once a day for 28 days and aim for overexpansion. In the mandible it was different, and this shows insight into how the appliance works. The Schwartz appliance is going to work from a dental alveolar basis. There's no mid-palatal suture to split in the mandible, so therefore activation is once a week to be able to achieve dental alveolar changes. Expansion is carried out for up to 5 months, and at that point the patient usually no longer requires retention because it intercuspates well with the opposing arch. So what are the long-term effects of using RME? Well, when compared from a long-term study from the ages of 12 to the ages of 20 by Mcnamara in 2003, he found that the arch perimeter was greater in the RME group by 4.5 millimeters at this 20-year time point than the controls who had no expansion that took place. He also showed some passive expansion that had taken place in the mandible for patients who had only had RME that took place. So is class 2 correction with RME possible? Well, he spoke about this, and what I liked was James Mcnamara's honesty about the answer. He didn't know why Class 2 correction improved with RME. He postulated the idea that with the bonded RME design, there is some intrusion that takes place posteriorly. Once it's removed, the patient postures forwards, and this results in an improvement. Now, there is a study by Guest in 2010 that showed 90% of patients who had RME had some improvement in the sagittal dimension. There was some Class 2 improvement, but only 50% of those achieved 2 mm correction. So the order of it is still relatively small. The lecture by David Sarver entitled Facial Aesthetics, Macro to Mini, Explore the Possibilities. Now, David Sarver is a very dynamic lecturer, and in this lecture he showed how he assesses patients, and he questioned the difference between the outcomes of assessment from the clinician's perspective and from the patient's perspective. And his lecture was really about how do we bring those two together. He spoke about 3 things we do to the face. We can either make it better, keep it the same, or make it worse. And it is really about getting our understanding of what changes we're going to make and also relating that to the patients. So starting off with the extraoral assessments, the typical clinician views from the front, the profile and smiling are not how people are perceived in society. And actually the patient view, he termed the social view, which is a 3/4 image. He spoke about how he used imaging software to show patients what they're likely to look like at the end, to give them the options in a visual sense. He spoke about his smile assessment, how tooth dimensional changes should have gradation to them, i.e. there should be a gradual change from the size of the incisors, for example, in the upper, to the lateral to the canine once viewed from that social view. And if there is a harsh change, that's going to lack aesthetics from a patient's perspective. He went on to speak about smile projection. Now, smile projection can be corrected through AP changes from jaw surgery or through orthodontics. The inclination of the upper incisors play a key part to the lip support, and that can also be changed through orthodontic treatment. He spoke about maxillary incisor display and how that forms a key part of how the appearance looks, not only from the front but also from the side, and we should consider gingivectomies or osteotomies when and where appropriate. Now, he gave a top tip at the end, and this was about incisor proportion. How if a tooth is short, he uses a crown former to quickly increase the height of teeth to allow him to view the effects of the aesthetic changes, which can be subsequently changed to something more aesthetic if required, but actually allows the proportions to at least be in play, and patients and clinicians can observe something in a reversible way. Next lecture is by Sylvain Chamberland, entitled Vertical Dimension and Facial Aesthetics. He started off by describing long face syndrome as described by Chang in 2011, and it's about having an anterior open bite, increased lower anterior face height. What's interesting, he mentioned the lower anterior face height proportions were different as well. Typically the average is for the upper lip to fall into the 1/3 and the lower lip and the chin to fall into the lower 2/3. For long face syndrome patients, the upper lip falls into 1/4 of this height and the lower lip and the chin falling into 3/4 of this height. So what are the treatment options for these patients? Well, there's typically orthognathic surgery, which used to be the convention, but there is now orthodontics with temporary anchorage devices for intrusion. So Sylvain got into it and described how do these TAD mechanics work. Well, in the maxilla, he uses a modified TPA with a mid-palatal temporary anchorage device. With some elastic chain going to the molars, this has shown that we can get intrusion of the molars of around about 1.8 millimeters. In the mandible, to have some intrusion take place, TAD is placed between the lower 6 and the lower 7 and the lingual arch, and this achieves about 1.2 millimeters of intrusion. Now, he described the overall effects are greater than the summation of these two numbers, and that's because of the auto-rotation effect. So with this intrusion, 4 millimeters of anterior overbite improvement can take place. But what about the average success of patients? Well, we know that about 60% of patients will achieve a 2 to 4 millimeter intrusion of the posterior segment with temporary devices. But what Sylvain was keen to mention is that there is a risk of relapse for these patients. About 16% of them, 1/6, will have a 2 to 4 millimeter relapse following posterior intrusion with TADS. Now, he gave some top tips about where to position TADS. So for the palate, for the upper arch intrusion, around about 8 to 9 millimeters from the upper posterior contact points. Anything greater than that, well, the bone's quite thin, you're getting quite close to the sinus into difficult territory. Now with palatal TADS, we're likely to roll in the molars, so it's important to perhaps expand the upper arch wire to counter this process. There's top tip for buccal TADS in the upper arch. Position it round about 5 to 8 millimeters above the crestal bone, between the upper first molar and between the second molar. Now there's a likelihood of flaring taking place here, but this time we constrict the arch with our arch wire to prevent that process from happening. How hard should we pull on these teeth when we're intruding them? So there has been a study by Aki in 2020, hot off the press, which looked at 200 grams of intrusion versus 400 grams of intrusion. In both cases, there was no difference that was found with the overall intrusive effect. So let's go lighter, guys, just to avoid any issues. Now, he spoke about intrusion of anterior teeth as well. Now, the TADs are positioned distal to the upper central incisors. They're 6 millimeter TADs, and he uses E-links to be able to intrude the anterior segment. He keeps the forces light at around about 100 grams. And that's because there is a risk here of having external resorption occur due to the proximity of the force to the teeth. Now, his protocol when it comes to long face syndrome patients, he likes to use segmental mechanics combined with his intrusion. That's between the 4 to 7 and from the anterior 3 to 3. He likes to put his TADs in the maxilla between the 5 and 6, as we've mentioned, and combine that with a TPA. In the upper arch, he also puts some buccal TADs between the 6 and 7. And E-links are his force of intrusion. Now, Sylvain then concluded by talking about clear aligner therapy. There's a lot that gets postulated about it, but there have been studies looking at clear aligner therapy and intrusion. This was by Harris in 2020, and it showed that overall changes to the overbite were positive, and we have 3 millimeters of improvement. However, there was no overall change in the vertical dimensions for these patients, and most of the changes took place through anterior extrusion, around about 1.5 millimeters of the upper anterior teeth, but also from the lower anterior teeth as well. Next was the lecture by Yves Czochrowska, entitled Trans-alveolar Transplantation for Impacted Teeth. This was looking at the scientific evidence in clinical practice. So she started off by going with some definitions. So autotransplantation is a surgical movement of one tooth to another location, whereas trans-alveolar transplantation is a surgical movement of a tooth to its correct position, i.e. its surgical uprighting. Now, she described this technique and its uses. So for impacted premolars, this is where we require significant change to the tooth position, or it's considered a hopeless tooth. Now, she mentioned the technique has to be done relatively traumatic-free. There has to be no contact taking place to the root. And now with cone beam CTs, one can have a printed version of the transplanting tooth, or the donor tooth, and prepare the recipient site for it. And the root length, she described having the earlier the root formation, the better the success, and she pinned this to surgical access to the tooth. So do they work? Well, the success rate of trans-alveolar transplanted teeth has been shown to be close to 100%. That's by Plaque-Wisk in 2014. The success criteria was for there to be no root resorption taking place, no periodontal tissues, and a crown to root length less than 1. She also mentioned that this should be the last resort, and if we have other options, we should explore them. There is always a risk of ankylosis with such surgical interventions. She then went on to speak about impacted canines. Yves then went to speak on about impacted canines. So, a common occurrence that takes place. However, when trans-alveolar transplantation has been carried out for these teeth, the survival in success isn't that great. Survival is around 75% on average, but success of these teeth, so the criteria we're looking at of no root resorption, no periodontal tissues, is around 50%. That's by Kalu in 2005. So she stated that actually we shouldn't really be doing this for impacted canine teeth, as the orthodontic treatment is pretty successful at around about 97%. This should be left for the severely ectopic canines, the hopeless teeth. She homed in on the ectopic mandibular canines, and suggests that this may be the treatment of modality for those teeth. Next lecture is by Yves Bolender, and it was looking at the difference between conventional, passive self-ligating and active self-ligating brackets, and is based upon his systematic review. Now, I really like this lecture because there are a number of points over the years that have been mentioned about self-ligating brackets, and he went through each one of them and he itemized them. It's quite exhaustive, but actually gave a very simple overview as to when self-ligating may be preferable and what the disadvantages may well be. So, there were 4 significant findings in favor of self-ligating brackets. That was the time to tie in an arch wire. It takes 107 seconds less, so in the order of almost 2 minutes to tie a wire in. When it came to the removal of an arch wire, it was 23 seconds quicker. Now, overall, when this was accumulated and we were to then postulate, well, what would happen in a full day, this could result in around about a 10% time saving just in changing arch wires. Bleeding on probing was significantly better when it came to passive self-ligating brackets, only at the 4-week mark though. An expansion of the intercanine width was also in favor of passive self-ligating brackets, but he qualified this statement, so there was only 0.5 of a millimeter increase in expansion in the intercanine width, so something clinically I would consider to be insignificant. So when it came to conventional ligation, interesting when it came to pain perception, conventional ligation in space closure in a 1925 stainless steel was shown to be less painful than either passive or active self-ligating appliances. When it came to expansion, it was better in the conventional ligating cases compared to the passive and active self-ligating. But again, he qualified this. It was shown to only be 0.5 millimeters of a difference. Again, I would consider that insignificant. And then it came to the active self-ligating cases. So those guys, there's a preference when it comes to alignment of the mandibular teeth. And actually it's supposed to be quicker by 10 days when compared to either active, or when compared to conventional ligation or passive self-ligation. Now the rest of the factors were shown to be no difference between all 3 types of ligation. So let's go over those. One was the treatment duration. Next was the total number of appointments was no different. Now, time taken to align the mandibular teeth between conventional ligation and passive self-ligation was shown to be no different. Pain perception in alignment was no difference between the two. Reduction in irregularity, speed of space closure, again, there was no difference. Now, we start looking at treatment outcomes, PAR, ICON, again, there was no difference shown between all types of ligation. Changes to the lower and size inclination is no difference, and root resorption has been shown to not be different between any of the forms of ligation. A really interesting lecture, and I really enjoyed learning from this particular chap. Next lecture is by Chun-Hsi Chung, entitled Periodontal Considerations in Orthodontic Treatment. So Chun started off by defining gingival recession as the apical shift of marginal gingiva to the level apical of the cemento-enamel junction. He described thick gingival biotype and thin gingival biotype, and we can clinically discern between the two by what Day-Rook recommended in 2009, which is simply periodontal probing into the sulcular gingiva, and if it's translucent, it's a thin biotype. If it isn't translucent, well, then it's a thick biotype. He described the thin gingival biotype cases. And what does that mean? Well, it means that they have a thin labial bony plate as well. They also have a narrow zone of keratinized tissue. Well, why is that important about the zone if they have some? Well, he showed that if there's less than 2 millimeters of this keratinized tissue, patients can have persistent inflammation taking place in that gingival area. Also, for the thin gingival type, there is a greater distance from the CEJ to the alveolar crest itself. That was shown by Cook in 2011. And of course, as a conclusion to this, there's a greater likelihood of breakdown when compared to thick gingiva. He described occlusal trauma and how it increases mobility associated with the tooth, angular bone destruction, but also loss of attachment. That's shown by Lind in 1974. Now, he also mentioned that if the occlusal traumatic relationship was to be removed, the actual recession defect usually improved. He then went on to speak about bone thickness, the other element that results in periodontal issues. And he spoke about how cone beam CTs have been hailed as solution to this. However, he urged some caution in interpreting the results, as we can get false positives that occur. There's a limitation in a cone beam CT as to the voxel size, so consequently it can show there's a significant dehiscence where there may not be one there. He spoke about orthodontic consideration when it comes to patients with periodontal issues, and it's to do with the thickness of the gingiva, but also the direction of movement. This is the bit of the lecture I enjoyed the most, where he actually broke down what happens when we move teeth forwards in the thin gingiva type, but also in the thick gingival biotype, so we can understand why what happens. So, to break it down, the thin gingival biotype, if we move the teeth forwards, there's a reduction in free gingiva, a reduction in the thickness of the connective tissue, and a reduction in the bone. So there's 3 things that change. That's different to the thick gingival biotype. Now for these guys, if we move the tooth labial, there's a reduction in the free gingiva, yes, and there's a reduction in the bone, but there's no difference in the thickness of the connective tissue. In the realms of periodontics, the connective tissue is what is sacrosanct and holy. He spoke about transverse expansion and how transverse expansion can also cause gingival recession. So where there is a risk of this process, he very much urged the use of surgical assisted expansion to prevent the dental tipping taking place and pushing the tooth outside of the soft tissue envelope. Next was Dimitrios kloukos, who looked at the long-term development of gingival recession in orthodontically treated patients compared to the untreated patients. And he described this topic of periodontics and orthodontics as having controversy within the field. There was a statement by Wenstrom in 1996, and it says that if the tooth is within the envelope of the alveolar process, it won't undergo recession. The question is, what happens when we push those boundaries? He described an investigation looking at periodontal changes with bonded retainers. This was by Mcnamara in 2013. The study actually looked at all teeth in the arch, but focused on where the lower bonded retainers were. It was interesting the trends that were observed from this study. The first was that as the patients grew older, so it was a 5-year follow-up study, there was generally greater recession in the mouth, not specific to one jaw. The second was that the first premolar was the tooth which had the greatest recession defects, followed by the upper left canine, followed by the lower right central incisor. Now he then went on to describe, well, what happens when we compare the orthodontic treated population to an untreated population. Now here's where the controversy stands. In a study from Mcnamara in 2013, it showed that there was greater recession in the treated patients versus the untreated patients. However, in a study by Gebestorff in 2018, when they matched for the malocclusions as well, it showed that actually there was greater recession in the untreated patients with a malocclusion when compared to a treated population of orthodontics. And the controversy continued. He then spoke about, well, what are the factors that can result in gingival recession? This was by Jos Vasily in 2010, and he looked at changes to loan size of proclination, width of the gingiva, thickness of the attached gingiva, oral hygiene, and thickness of the symphysis. And as you may expect for such a controversial topic, there was no conclusion or correlation drawn between these changes that took place. This had led the author to then carry out his own study, which is currently undergoing. Now here they're looking at a whole host of factors, including the biomarkers that are present, cephalometric changes, clinical outcomes, and at this point in time they're 1 year post-debond, comparing a treated population to an untreated population in a prospective fashion. So far there's no strong relationship between gingival recession and having had orthodontic treatment, but I very much look forward to seeing the results from this study, as it looks as though it may be able to answer the question in a more comprehensive way from the literature that's currently out there. Next was Chris Chang, who spoke about the gummy smile and its correction. Actually, Chris Chang's lecture was mainly based around his favourite use of TADs, and that was in the buccal shelf, ramus TADs, infrazygomatic region, and also anterior TADs. To start off with buccal shelf TADs, he exemplified this with a class 3 case. So where does the buccal shelf go and what is it? Well, it's a temporary anchorage device which is inserted buccal to the lower 6 and lower 7 region, the lower molars. The advantage of this is that it's not associated with the roots. This allows the entire arch to be distalized, and he described en masse retraction occurring directly to the TAD from the arch itself. And he described a case where there was significant change of 11 millimeters, and this was possible, one, through the distalization itself, but also the moments that took place. Now, the moment is a counterclockwise moment. There's a change that takes place in the occlusal plane. Coupled with this buccal shelf TAD, class 2 elastics can be used. And that is correct, it is class 2 in a class 3 case. That's because the elastic goes from the upper segment to the lower buccal shelf, therefore allowing correction of the upper incisor inclination. He described the key to the success of these cases is also to use self-ligating brackets. Described it as allowing freedom of movement to take place of the teeth. Described it similar to the mu from previous. He then went on to describe buccal shelf TADs being used for scissor bites in the posterior quadrants. This patient had a complete scissor bite. The buccal shelf TAD was placed in the same region, the buccal to the lower 6, lower 7, and this time power chain was attached directly from this lateral or buccally placed TAD to the lower posterior teeth. This uprighted those teeth, and the TAD could stay where it was as it's got no involvement of the roots. And this case actually won an award for Chris Chang in the AJODO case prizes from 2018. Finally, he spoke about using a buccal shelf and what the failure rate of it was. And it's been shown to be 7% failure compared to conventional TADs as an overall, which has been reported as high as 19%. That's by Park in 2004. When it comes to using ramus TADs, he described this as his get-out-of-jail clause when it comes to impacted second molars. He positions a TAD in the ramus. That's a 14mm TAD that's placed quite high up. He places such a large temporary anchorage device because there's lots of tissue in the way, including the medial pterygoid muscle. He then went on to speak about his favourite maxillary TAD, which was the infrazygomatic crest temporary anchorage device. Now his reason for favouring this was similar to the buccal shelf TAD, is out of the way of the roots. So it's positioned lateral or buccal to the 6 to 7 in the upper posterior segment. Now initially the path of insertion is 90 degrees. He described that when it hits bone to then go at a significantly oblique angle, approximately 70 degrees. So the entire TAD actually remains buccal and doesn't go onto the palatal aspect. He described as there being no roots here, so it's more likely to stay in place. And again, he likes to leave quite a bit of the TAD out of the actual gingiva. He favours 5mm of the TAD to be visible. He described using TADs in the anterior segment to intrude the anterior teeth for a gummy smile. This is where the TADs are placed distal to the upper central incisors. He favours a 1.5mm TAD at 8mm length and power chain to intrude. Chris Chang has a journal, the Journal of Digital Orthodontics. There's a reference for it if you wish to have a look at his cases. Next was Junji Sugawara, who spoke about how has skeletal anchorage changed orthodontic strategies for class 3 correction in adults. I really enjoyed Junji's lecture. He spoke about his own experiences before using skeletal anchorage systems and orthodontic patients, and then also using it afterwards. And his focus was just on class 3 cases. So he described that without skeletal anchorage, when it came to camouflage cases, it would require extractions. Also the use of complex orthodontic mechanics, such as mu, for controlling technically challenging situations. When it came to surgical orthognathic patients, there would be a convention as to when surgery would happen, i.e. pre-surgical orthodontics, time-consuming, followed by the surgery and post-orthognathic orthodontics. Now then he went on to describe how having skeletal anchorage systems has changed this process, starting off with a class 3 camouflage case. He now positions his skeletal anchorage system in the buccal segment in the lower posterior region. He carries out relatively simple mechanics. He indirectly ligates the plate to the premolar and then has some push coil running from the premolar to the molar. He therefore has indirect anchorage to that premolar and the molar distalizes. He then went on to describe how he can now protract in class 3 cases using a skeletal anchorage system. So in the upper arch, he places his skeletal anchorage system and it's positioned so it comes out in the posterior segment in the premolar area. He therefore indirectly ligates it to the primary molar and simply has some push coil running from the molar to the premolar region. This allows the entire anterior segment to be advanced. He spoke about distalization using skeletal anchorage systems. This time he uses a Y-shaped design to the plate, positions it in the zygomatic buttress, and indirectly ligates it, this time to the canine. He then uses push coil from the canine to the first molar, and it distalizes the canine. He then went on to speak about complex orthognathic patients, and I thought this was really interesting, how the skeletal anchorage system has now facilitated him carrying out surgery first. So patients have the orthognathic surgery and also have the anchorage system placed in the upper posterior segments. Now in the class 3 cases, just to recap, there's usually decompensation required for the upper incisors, i.e. we need space in the upper arch. What he would do is that he would have surgery first, and patients would be left with a reasonable overjet at the end of the surgery. Following that, orthodontic appliances were placed. Now he uses the skeletal anchorage system to distalize the upper molars. That allows him to decompensate the upper incisors and to close that overjet that was produced. Now skeletal anchorage systems have allowed him to be predictable in the final position of the upper incisors, and also these cases have been treated within less than a year. It was great to listen to this lecture from an expert in the field. Next lecture was by Mitsuru Motoyoshi. This was looking at the safety placement of orthodontic anchorage devices, or TADs. He spoke about how the TAD failure rate has been reported at up to 5%. Now the main cause of this failure, over 80% of them, is due to contact with a root surface. Now I like this presentation because it's not often that failures get discussed and get discussed out loud. But what Mitsuru did is that he looked back at a number of studies and cases treated within his department to look at what is going on when TADs fail. So to start off with, which teeth do TADs contact when they fail? A paper by Moon in 2006. In the maxilla, he found that when the TAD was placed, when it failed, it was usually the tooth distal to the point of insertion that it made contact with. It was interesting, the mandible, there was a story of two different things going on here. So on the right-hand side, the TAD usually made contact with the distal tooth. But on the left-hand side, it was usually the mesial tooth it contacted and then failed. This, in my mind, follows if the person inserting is right-handed, they're more likely to slope backwards when inserting the right-hand side, whereas if they're on the left-hand side, they're likely to go more towards the center, and therefore go mesial. How to avoid contacting the root? Well, there's been an idea that if one goes at a 30-degree angle to the path of insertion, they're likely to avoid making contact with the root, and that is true. He gave the information behind it, and that's because there's greater root divergence that takes place the higher apical we go. We're just less likely to hit teeth. Also, there's greater cortical plate engagement because we're going at an oblique angle into the cortical bone. So therefore it's more stable. He then went on to speak about, well, what's the proximity to a root from a radiograph? And does that help us work out where we're going? Actually, he found that it isn't. Even on a plain radiograph, if the TAD looks as though it's going towards the root or into the root, there's still an 80% chance of it being successful. He spoke about greater failures taking place of TADs in the mandible, and he hypothesized as to why this was, and then demonstrated some evidence. The idea of having micro cracks take place on insertion. Then he showed a case where a patient had an insertion torque of 15 newtons, and a crack was definitely present around the site, whereas with 10 newtons, there didn't appear to be a crack. He spoke about root fractures taking place to teeth. Now, the isolated case reports about this. However, it's important to mind that a root fracture can take place if we go significantly off course. He then spoke about, well, where are the successes of putting TADs in? And actually, one of the highest success rates takes place within the palate. And he gave some key tips, some hot tips as to how to get a palatal TAD to stay in without having failure. He advised avoiding the mid-palatal suture itself, as it can be an unpredictable place for retention, placing it anterior to the first molar. He also said actually the embedding amount of TAD should be at least 4.5 millimeters. He recommended pre-drilling when it comes to positioning a palatal TAD, as it's shown to have greater success. And what I thought was really interesting, he explored the torque in the upper arch. So he showed that actually the higher the torque, the greater the chance of stability, up until about 30 newtons. And after that, actually we're more likely to get failures. That's it for the first episode of Orthodontics in Conference. I do hope you've enjoyed it. We've managed to go through 14 lectures, summarizing it in less than an hour. That's a whistle-stop tour of the IOC first day. I've learned a lot from it. Hope you guys have benefited from it as well. Look forward to day 2, and if webinar fatigue hasn't taken me to the sane asylum, there may well be a day 3 as well. Please do subscribe and let me know your feedback, guys. Look forward to hearing from you. As I mentioned before, the notes of each individual lecture will be present on the website, www.orthoinsummary.com, and that should be up by the end of the week.